There's some really fantastic things happening within the world of male infertility. One of the most hot topics within male infertility is advanced maternal age, and Mike Eisenberg's group did a retrospective review of the National Vital Statistics System and looked at parenting patterns. They found that U.S. paternal age is increasing across all age groups, all levels of education, and all regions, and that births to men aged 40 and 50 have more than doubled in the past 40 years. We know that as men age, there's a decline in semen parameters, but this group actually looked at men who have impaired hypospermatogenesis to start with and the impact of paternal age in mice. So they took a group of men with Sertoli cell only syndrome, and they did testicular biopsies on these men, and then they looked at the testicular histology. And what they found was that with increasing paternal age, there was a decrease in seminiferous tubule diameter, a decrease in an increase in interstitial fibrosis, and an increase in interstitial inflammation. And thus, for men with Sertoli cell only and possibly other hypospermatogenic states, we should consider early surgical sperm retrieval in these men. Lee et al. Has been one of the first groups to look at the impact of genetics on advanced paternal age. So we know that some genes will, with exposure to environmental and lifestyle exposures, that aberrant genes can get passed on to offspring. So he took mice of different ages and different exposures and sacrificed them. And what he found was that at different ages, there was a distinct microRNA profile found with paternal age. And there was an age-dependent decrease in RNA surveillance for transposable elements. So this may have implications for the type of genes that are being passed on to progeny from fathers of advanced paternal age. Shifting gears to medications, Jim Hoteling's group put out a pair of abstracts looking at the effects of medications on semen parameters. This was a retrospective review, but for statins, they found that there was a mildly decrease in ejaculate volume of 0.3 milliliters, but then an increase in sperm viability, but no change in the standard semen parameters. For proton pump inhibitors, there was no difference in semen parameters or any of the other variables that they looked at. Mike Eisenberg's group looked at the effect of clomiphene on infertility and demographics. So clomiphene is commonly used by the infertility community for the treatment of hypogonadism and male infertility in an off-label fashion. They looked at the market claims database, and they found that 12,000 men were using Clomid. The mean age that was being used was 38 years. The median duration of use was 3.6 months, and 60% of these men were off of the clomiphene within 6 months. Now, because this is an off-label use, one thing that we always counsel patients is that it's difficult for us to express all of the possible side effects. And what's reassuring is that in the cohort that Dr. Eisenberg looked at, there was no increase in the risk of DVT, ischemic heart disease, or cancer in men taking clomiphene for a short period. Shifting gears to surgical outcomes, Dr. Grover's group compared the findings of the gross fluid at vasectomy reversal as compared with the microscopic findings. So typically at the time of vasectomy reversal, we aspirate some fluid from the testicular stump and look at it under a bench microscope to determine if sperm are present, and therefore if we're performing a vaso-vaso or a vasoepididymostomy. Some centers may not have a bench microscope, and so some clinicians will actually just use the gross fluid characteristics to determine which operation to perform. However, even in some patients who had favorable fluid characteristics, so thin, copious fluid, 10% of those patients did not have sperm in that fluid. Therefore, it reinforces that we do still need to be using the bench microscope for these operations, because otherwise 10% of these men are going to end up with an operation that will likely not be patent. There were several abstracts looking at various aspects of varicocele repair. This is Jay Slandlow's group out of the University of Wisconsin, and they looked at the timeline for improvement in semen parameters after varicocele repair and its relationship to reproductive outcomes. What they found was that 57% of men had an improvement in their semen parameters as defined as an increase in total motile count by more than 50% from baseline. 69% of these men had their improvement within 3 months, but then if you gave these guys an additional 3 months, another 24% would have an improvement in their semen parameters. And the men who had an improvement in their semen parameters also had an improvement in their clinical pregnancy rates. There was also some novel techniques that were explored for varicocele repair at AUA this year. Dr. Tamina looked at injecting indocyanine green angiography during varicocelectomy to aid in identification of gonadal vessels. Dr. Kayan's group looked at what to do with recurrent or persistent varicoceles. So they took a group of men who had either recurrent or persistent varicoceles, and half of them underwent a repeat varicocele surgery and half of them were randomized to observation. Men who underwent a repeat varicocele surgery had higher sperm counts, 15 million versus 45 million, higher pregnancy rates, 39% versus 52%, and lower miscarriage rates. The Cornell group continues to advance the microsurgical testicular sperm extraction. So typically when a microchessie is performed, small samples of testicular tissue are given to the andrology lab, and an embryologist searches through that tissue to find small foci of sperm. In this abstract, the authors took testicular tissue from fresh cadaveric specimens from men who were known to have normal spermatogenic potential, and then they took samples from failed microtestes. They then performed fluorescence-activated cell sorting on these specimens. Within the ejaculate specimen, you can see that there's a spike at the haploid point, indicating a spike for spermatozoa. And when they did the same assay to the microtestis specimens, there's another small peak at the haploid specimen mark. Therefore, fluorescence-activated cell sorting may at some point provide a way for us to find sperm from a very low sperm environment, short of individually hunting for sperm within this tissue. Shifting to database work. So this is data from the University of Toronto. There's a group of fertility centers that are administering questionnaires to patients and then collecting these questionnaires to sort of pool our data and be able to make more meaningful conclusions about male infertility. At this point, there's 2,500 completed surveys, and the initial findings were presented at this year's AUA. So the most significant findings were that approximately 10% of couples are being treated by the reproductive gynecologists using some form of assisted reproductive technology with no male factor evaluation. And when you actually look at these men, some of these men have a reversible cause for their infertility, further reinforcing our need for education outside of the urology community. And finally, there was a very well-attended plenary session on the Zika virus by Dr. Turbet. Zika is also a very hot topic now, and as we know, it can cause microcephaly as well as some other adverse reproductive outcomes. Assays are now commercially available. Most of them have a relatively good sensitivity, but a very high specificity. She looked at the duration that we find Zika virus RNA within bodily fluids, and interestingly, it's found much longer within the semen as compared to serum or urine. So 81 days in the semen as compared with 39 days in urine and 54 days in serum. Monoclonal antibody studies showed that Zika seems to localize to the mouse epididymis and the testicle as opposed to other tissues, which may explain some of why there's a prolonged shedding. And the current CDC recommendations are for men to wait 6 months after either exposure or any symptoms before they try and achieve a pregnancy. So again, I want to say thank you to the AUA. Congratulations to all of the